Today we are going to discuss about the ulnar nerve examination, how to do it competently in a systematic manner when it is given to you in the examination. In the examination, when you are given a case of suspected nerve injury and you suspect it could be the ulnar nerve, by any indication they are written on the question paper, you should do the nerve examination in a different way. It is not like a joint examination. And secondly, when you are given a suspected case of ulnar nerve injury cases, you are asked to do it clinically. You have to do the examination of the ulnar nerve to detect whether there is any injury of the ulnar nerve. And second part of it is, if there is an injury of the ulnar nerve, where is the likelihood of the injury? Is it the lower ulnar nerve injury or is it the higher ulnar nerve injury? That is what is under the question. In short cases, this is what you have to do. In long cases, you can do for other parts of the examination, such as looking for the causes. What could be the causes of the ulnar nerve injury? But in short case, that is not required. So we will start from here, how to do it. So basics, introduction, patient's consent, looking for a chaperone, ensure privacy, proper positioning of the patient is, patient can be asked to sit on the examination, put a pillow on his lap, on her lap, and you can start the examination. Exposure should be adequate, wash your hands, and start the examination. The steps of the examination should be under following headings. You must look for some pathognomonic signs. You have to test the muscle power supplied by the nerve. You have to grade it. You have to do the sensory examination innervated by the nerve. You have to look for the reflexes wherever possible. In the ulnar nerve, there is hardly any reflex that you can see. And lastly, we will do the T-nail sign in a case of suspected ulnar nerve injury. So general abnormalities that you can observe in any nerve examination is first the deformities peculiar to that particular nerve. And there could be loss of air in the cutaneous supply of the nerve. There will be loss of sweating in the area. There will be brittle nails, scars of cigarette burns in the cases of the hands, and pressure sores in the foot. And there will be particular muscle wasting supplied by the nerve. In the case of ulnar nerve injuries, you will mark ulnar claw hand deformity, Wartenberg sign. Muscle wasting will be seen in the first dorsal interosseous. There will be guttering of intermetacarpal spaces. There will be adductor pollicis muscle wasting, hypothenar muscle wasting, and there will be wasting of the medial half of the forearm muscles in the case of upper ulnar nerve injuries. Loss of sweating and loss of hair in 1.5 medial fingers corresponding palm and dorsal area, and there may be brittle nails of the little fingers. There is some autonomic function of the nerve, is no exception. Thin skin covers most of the body and contains sweat glands, in addition to the hair follicles, hair erector muscles, and sebaceous glands. And their dysfunction leads to hair loss, loss of sweating, and brittle nails. So the first look we will be looking in the case of ulnar nerve injury is ulnar claw hand deformity. You can see it, ulnar claw hand deformity. We are going to discuss it in a bit more details. Remember the difference between the total claw hand deformity, which is caused by both median and ulnar palsy. So it is a total claw differentiated with only ulnar claw hand deformity. Now the question is, what do you mean by a claw hand deformity? Claw hand deformity is flattening of the transverse metacarpal arch and longitudinal arches, accompanied by hyperextension of the metacarpophalangeal joints and flexion of the proximal interphalangeal and distal interphalangeal joints. So the transversal arches along with the longitudinal arches are lost, and there will be hyperextension of metacarpophalangeal joints and flexion of PIP and DIP joints. Why is there hyperextension of the metacarpophalangeal joint at all? The reason is the lumbrical muscles of the hand flex the fingers at the metacarpophalangeal joints and extend them at the interphalangeal joints. Once their ability to flex the metacarpophalangeal joint of the little and ring fingers is gone, the long extensors hyperextend the metacarpophalangeal joint. Why is there hyperflexion of interphalangeal joints? The extensor digitorum gets help from the interossei and the lumbricals to extend the interphalangeal joints through the extensor hood, or it is also called the extensor expansion. At the interphalangeal joints, the extensor digitorum has to overcome and counteract the flexion force that is exerted by the flexor digitorum profundus. The extensor digitorum, though still active in the case of ulnar nerve injury, cannot extend the interphalangeal joint because there is no assistance it is getting from the lumbricals and interossei muscles. Why is their little finger more flexed than the ring finger? The reasons are because of inherent increased laxity of little finger, MP joint, volar plate. In addition, approximately 50% of the patients have median nerve cross innervation to lumbricals of the ring finger. Now the question is how to differentiate distal from the proximal nerve lesions. This is also called ulnar paradox. In high nerve lesions, means the lesions are at the level of elbow or above the elbow. The clawing is less because flexor digitorum profundus cannot flex the interphalangeal joints. About the sensation, in high ulnar nerve lesions, there will be loss of sensation in dorsal and ventral aspect of whole of the fifth finger and medial half of the fourth finger, along with the corresponding palm areas. In low nerve lesions or lesions around the wrist, the clawing will be more severe because now the flexor digitorum profundus is acting and it will flex the interphalangeal joints more. About the sensation at the dorsum of the fifth finger and medial half of the fourth finger will be intact because of the dorsal sensory nerve may be spared, but numbness or the anesthesia of the polar aspect of the fifth finger and the medial half of the fourth finger will remain as such. While the claw hand sign of the benediction may appear very similar, they are not the same. Claw hand occurs due to an ulnar nerve injury, and it is occurring usually when there is a distal lesion. The fourth and fifth digits are flexed, and the patient cannot straighten these two fingers. Whereas in the sign of benediction, when you ask the patient to make a fist, the second and third fingers will remain extended. So it is by the action that you see sign of benediction, and you see the sign of claw hand when the patient is keeping the hand without any active extension or flexion. We will be seeing wasting of adductor pollicis on the first loop, and it is the guttering of the first web space. Wasting of the hypothenar muscle eminence that you will be seeing in the case. Here you can see it, here it is normal. There is a Wartenberg sign. What is it? It is involuntary abduction of the fifth finger, and it is caused by unopposed action of the extensor digiti minimi, which is supplied by radial nerve and which remains spared. And why it occurs? Because the extensor digiti minimi is attached on the ulnar aspect of the phalanx. What will happen when the damage occurs at the wrist? The paralysis of the following muscles will occur: adductor pollicis, palmaris and dorsal interossei, medial two lumbricals, and hypothenar muscles. Sensory functions: the palmar branch and superficial branch are usually severe, but the dorsal branch is unaffected. This results in sensory loss over the palmar side of the medial 1.5 fingers only. Dorsal side is spared. And in case of damage at the wrist, the forearm muscles are not affected. So we will start testing the individual muscles. How to test the adductor pollicis? It is a Froment sign. Patient is asked to hold a piece of paper between the thumb and the index finger, and the paper is pulled away by the examiner. In a normal case, they should be able to hold the paper without any difficulty. What will happen if they will be unable to hold it? Instead of adducting the thumb, they flex the thumb and interphalangeal joint and try to maintain a hold on the paper. So while you are pulling the card or the piece of paper and the patient is flexing the interphalangeal joint of the thumb, it means it is a case of ulnar nerve injury. So this is how it is happening. You do it like this, and the patient will flex the interphalangeal joint of the thumb like this. Adductor pollicis muscle testing can be done alternatively. The test the patient's ability to grasp the sheet of the paper, which is held between thumb and the anterior aspect of the index metacarpal, and then you pull it. The function of the interossei, palmar interossei are paired, palmar adduct, whereas dorsal interossei is dab dorsal abduct. Testing the first dorsal interosseous muscle, place the patient's hands in a palm downward position on a flat surface and ask him to resist while you attempt to adduct the index finger. Igawa's test is again the test for the dorsal interossei of the middle finger. With the patient hand kept flat on a table with palm down, the patient is asked to move his middle finger sideways. It is like this. And then you can see the patient can move it. This is called Igawa's test. Testing for the palmar interossei has several methods. One is card test. So ask the patient to hold a card between his index and the middle finger. Here it is not shown. And try to pull it. Patient can hold in case of ulnar palsy. The method 2 is ask the patient to hold a sheet of paper or card between little and ring finger, whereas the fingers must be fully extended. In complete palsy, we have just seen the little finger is normally held in abduction and the patient will be unable to grip the card at all. The second palmar interosseous muscle testing is on a flat surface, the patient adducts the index finger against the resistance given by the examiner. Remember, the long flexors of the fingers, like flexor digitorum superficialis and profundus, can substitute for digit adduction when the fingers are flexed. To eliminate these substitutions and isolate the interossei, the finger should be in full extension at the metacarpophalangeal joints. How to test the lumbricals? We know the lumbricals has got two functions. One is flexion at the metacarpophalangeal joint and extension at the interphalangeal joints. So testing the third and the fourth lumbricals, immobilize the metacarpophalangeal joint of these two fingers in hyperextension and then test the extension of the proximal interphalangeal joint against resistance given by you as an examiner. Testing for the abductor digiti minimi, place the hand on the flat surface and ask the patient to resist while you as an examiner attempt to adduct the little finger. Opponens digiti minimi, which again is a part of the hypothenar muscle. Let the patient hold the volar pads of the distal thumb and the fifth finger like this. While the patient maintains this position, try to force the proximal digit and distal fifth metacarpal away from the thumb. Palmaris brevis muscle, it tenses the skin of the palm on the ulnar side during a grip action. Ask the patient to abduct the fifth digit and then instruct them to contract the hypothenar eminence simultaneously. Skin corrugation will occur. See this part. This is palmaris brevis. flexor digiti minimi is assessed by immobilizing the interphalangeal joints of the fifth digit and having the patient flex the joint against resistance. It is very difficult to isolate this muscle's function because flexion of the fifth digit's metacarpophalangeal joint is performed by not only the flexor digiti minimi muscle, it is the main function of the lumbricals and interossei as well. What will happen when there is an injury at the elbow? There will be muscles who will be affected in the forearm, and they are flexor carpi ulnaris, medial half of the flexor digitorum profundus, and palmaris brevis. They have to be tested. Remember, the flexion at the wrist can still occur, but it will be accompanied by abduction due to the fact that flexor carpi ulnaris is paralyzed. The flexion of the DIP joint of the little finger is not possible because of paralysis of the medial half of flexor digitorum profundus. All other tests that we have already done will be found positive. And it adducts and flexes the wrist at the same time. It acts in tandem with the flexor carpi radialis to flex the wrist, with the extensor carpi ulnaris to adduct the wrist. So it has several functions. There are several methods of performing the test for flexor carpi ulnaris. Method 1 is, while patient abducts the ipsilateral fifth digit, observe and palpate the flexor carpi ulnaris tendon, which is just proximal to the wrist. Method 2 is, place the hand on the flat surface and ask the patient to resist while you attempt to adduct the little finger and patient resists it. Again, you will feel the same flexor carpi ulnaris tendon being prominent. Method 3 is, let the patient flex his or her wrist against resistance in an ulnar direction, which is the primary function of this muscle, and feel for the tendon of flexor carpi ulnaris. Method 4 is, ask the patient to resist while you attempt to extend the flexed wrist and feel for the contraction of the flexor carpi ulnaris. Flexor digitorum profundus is tested when you immobilize the proximal interphalangeal joint of the fifth digit like this, immobilized, and while the patient flexes the distal interphalangeal joint and you resist it to see the grading of the power. The sensory functions, the palmaris cutaneous branch innervates medial half of the palm. It is in the palm. Dorsal cutaneous branch innervates dorsal surface of the medial 1.5 fingers and associated dorsal hand area, and superficial branch innervates palmar surface of the medial 1.5 fingers. In ulnar nerve injury, almost all will be affected. Remember, there are two areas of the cutaneous nerve supply. One is called overlap zone and another is autonomous zone. An area of the skin innervated by only one nerve is called autonomous zone. Knowledge of the autonomous zone is critical to assessing sensory innervation. sensory loss on the dorsum is indication of a loss proximal to the wrist. Remember the autonomous zone for the ulnar nerve? It is distal phalanx of the little finger. Don't forget to do the T-nail sign. It has to be done in the cubital tunnel near the medial epicondyle. Tap over the cubital tunnel and look some type of paresthesia in the course of the nerve distribution. So thank you very much. For any queries, you can contact me on the mail given here. Thank you very much.